Happy Thursday Night Live! We are here with another very important and incredible speaker for you guys. We have Dr. Angie Tenholder. Thank you so much. I know that recently we asked who else knows about BabyLase. A lot of our members have been asking about more information on BabyLase. So somebody recommended you and you are here today. And the topic is amazing. It's all in your head, changing minds one smile at a time through neurodevelopmental dentistry. So this is even better of a talk. I hope you guys enjoy today. We are actually recording this on a Friday. If you're an Array Circle member, you have early access to this talk, and you're also here with us live, so you can interact, you can ask questions. If you're watching this on a Thursday, enjoy, share this with your colleagues, invite them to join Array Circle. And make sure you are in our directory. We have a multidisciplinary directory. It is free for both professionals and patients to join and search. You can just go on airwaycircle.com, click on directory, make sure you're logged out if you're a member, and you can create a new account or just add yourself to the directory on the bottom. We have over 3,000 visits to the directory every month. It's an incredible free resource that Array Circle offers the community. So introducing our speaker today, Dr. Angie Tenholder. She's an integrative health center dentist with decades of clinical experience and a passion for holistic oral body wellness. As president of the American Board of Craniofacial Dental Sleep Medicine and a diplomate and fellow of multiple prestigious dental organizations, she brings deep expertise to the field. Dr. Tenholder is the founder of the Synergy Academy and the creator of BabyLase, offering in-depth training on techniques such as ALF Therapy, OraLase, and RestOralase. A seasoned educator and innovator in neurodevelopmental dentistry, she is widely recognized for her contributions to national and international conferences, courses, and webinars empowering providers to deliver transformational whole body care. Thank you so much for accepting our invitation and for being here with us today. Did I miss anything?
No, you did great. Thank you for having me here.
We're so excited for this talk. You're welcome to share your screen. And then at the end, whoever is watching live, you guys put your questions in the comments and we in the chat box, and we're going to ask them. Ta-da! The floor is yours.
Well, once again, thank you so much for having me. There's been a lot of people that I've had come through my courses and my organization that are part of Airway Circle. So I just really value everything you guys are doing. You're doing amazing work. So thank you for that. So the topic of today's presentation is it's all in your head. And neurodevelopmental dentistry is a concept that we teach in our courses and something that is a little bit unusual to some people because that's not our traditional training. So literally, the definition of neuroplasticity is changing your mind. And that's what I like to do today by giving you a little bit more information. And just as a brief kind of like if you want to learn more about all these different topics we're talking about, you can go to our YouTube channel at the Synergy Academy. So a little bit more about myself. And as Renata said, I've been a dentist for a long time now, over 3 decades. I have my fellowship and diplomates and all these letters behind my name, as she mentioned. But my most important letters are MLM and MRS. I am the mom of 3 kids, all who needed my professional skills as well as my personal love for them to be able to help them through life. And same as my husband, who has benefited so much from ALF Therapy and OraLase and RestOralase that, happy wife, happy life. It made me really happy to see him get better by what I could offer him. And I think most of the people that I've talked to that come through my courses have a huge investment in their families as well as their patients. So when I went through this journey trying to figure out myself, I was my first ALF patient, I learned cranial osteopathic procedures. I'm a sports dentist. Academy of Sports Dentistry as a soccer mom, biological dentistry, and then ALF therapy changed my life, saved my life, as well as OraLase, BabyLase, and RestOralase being a huge part of what I do, because I initially did not want to work with babies, and God said, here, hold my beer, and I got babies brought to me that needed my help. And so we figured it out, and it created miracles, and I want to introduce you guys to that. So disclosures is that I'm an instructor for the Synergy Academy, through the Academy of Craniofacial Pain as well, through the Sleep Board, the ABCDSM, and I'm a faculty in the ASAP pathway as well. I've been honored to be asked to speak for multiple organizations. And once again, resist, persist. I never wanted to do public speaking, but it is how I can get the word out there about how passionate I am about all the things that we do. And I'm a perpetual student, just like I'm sure all of you guys are as well. And so throughout my life, I'm always wondering, am I missing something? Is there just a little bit more out there that I'm supposed to know? Like I'm packing for a vacation. It's like, did I forget anything? Am I missing something? And the same with my educational journey, because I've been everywhere. I've done everything, it seems like. And dental professionals are often the first responders and greatest advocates for airway health. Such a passion of mine. My husband was diagnosed with obstructive sleep apnea when he was in the Air Force, but my baby had birth trauma. So it all comes together in one big, beautiful circle of life. And the price of greatness is responsibility. And that's a quote from Winston Churchill. And once you step on this path, you do have the responsibility. Every time you look at a patient or a friend or a family member, you think, what can I do to help? Help those caterpillars turn into butterflies. But what if you could figure out how to incorporate the power and the sophistication of optimizing neural circuits, neurology, to improve your treatment outcomes? And what if you could have access to the knowledge how to help and identify your at-risk and or your non-resilient patients and have a deeper understanding of the toolbox to better serve them? And another question, what if the obstacles in understanding these concepts could be overcome literally by changing your mind about the opportunities that are possible by implementing neuroplasticity as a concept into a practice, and how dental professionals can add this skill to their toolbox? And what if the answer to these complex challenges of the craniofacial region just didn't sound like one of these simple, commonly heard statements that I see on both patient groups on Facebook and patients that come into my office, but also providers over the years? Well, if you're having a problem, it must be an airway issue. Well, I'm going to challenge that a little bit, because airway function is primarily neuroreflexive and secondarily structural, and the literature supports that. Oh, and there's another one. While the patient's apnea-hypopnea index was reduced, therefore treatment has been successful. Actually, now we know that apnea-hypopnea index is a great indicator of insurance reimbursement, but an inadequate indicator of overall health. And there's more, just to challenge you. I can see that the patient's tongue tie is causing all of the problems. The problem is that the research shows that the floor of the mouth is composed of fascia, and that can't easily be visualized upon observation. And here's another one. The patient is still suffering because her tongue tie release was incomplete, a quote, incomplete release. Well, what if there were factors that were not considered, such as the neurological and fascial restrictions through a surgical release? And was the assessment and therefore the treatment incomplete, and maybe not just an incomplete surgical procedure? Possibly. Oh, here's another one. There's not enough intermolar distance, and expansion will solve all of the patient's problems. And sometimes it does, and sometimes treatment outcomes can be successful, but not always, and not always without risk and adverse effects. So today, what my presentation is going to be about is changing minds one smile at a time. So we're going to be learning about how to define neurodevelopmental dentistry and bring awareness to neuroplasticity, neuromodulation, and neural circuits as we apply this information to trying to get ideal treatment outcomes. We're also going to be looking at how to avoid the common errors of oversimplifying complex conditions as a natural consequence of the limitations of who we are, what we know, and what we do. And then we're going to combine common sense principles and evidence-based practices with the most recent literature on tongue restrictions and sleep dysfunction, and it might challenge a few paradigms. So sometimes when you go into something as complex as I'm getting ready to present to you, it's often easier to break things down into the parts. Kind of like when you get a meal served at a restaurant. It started by gathering ingredients, and we're going to start with definition and concepts. Then we combine those concepts in making a meal when you're cooking it all up. And think about that as planning your treatment plans and pairing coordinated care. And then we're going to create the message or treatment modality that's going to be provided to support patient care. And that's kind of like cooking. And my kids they're like, Mom, can you give me your recipe for this? I'm like, I wish I could, but I just figured out over the years, I don't cook with recipes. Now they're helpful. They're really helpful, just like research is really helpful. But evidence-based medicine is actually learning to do it on your own and using your head and not just the research. So then we serve and enjoy, and that's what I'm doing 3 decades into my career. So the recipe for the evolution of neurodevelopmental dentistry, let's talk about the definitions of what those are and how we as dental providers influence neural circuits. Evolution, the definition of it is the gradual development of something, especially from a simple to a more complex form, and that's what I'm going to be doing today. Neurodevelopment is the formation of neuronal pathways and synaptic connections that are responsible for brain development and function, which we don't always think about with dentistry, but there is a very strong mental-dental connection that we're going to be exploring today. And that's why I developed this little cartoon on the right, because if the tongue is not plugged into the brain, it's kind of like you calling your IT guy and saying, my computer's not working. What's wrong with it? And the first question they ask is it turned on and is it plugged in? And have you tried to reset it? Have you tried to reboot it? We need to think about it that way with the swallow, because the swallow is a rhythmic motion that begins at approximately 4 weeks in utero and is affected directly by maternal stressors, not just the apoptosis and the tongue tie presence or absence, but maternal stressors. And there's a lot of stressed out moms these days, and that is affecting the neural development and therefore tongue function of their babies. We do know the mechanical forces influence the size and shape of the maxilla and the cranial base, which is a reflection of the development of the swallow. We also know that neurological influences from the swallow either support the development of functional or of dysfunctional trigeminal neural circuits. And we're going to be talking about the importance of dysfunctional trigeminal neural circuits as related to the etiology or actual cause of sleep apnea. And the swallow is heavily influenced by cervical mechanics. Like, for example, a baby that's born and they have a restricted upper cervical spine that's never addressed, it's always a potential that that baby's tongue dysfunction was caused by the neck dysfunction. And that was my story with my baby who had birth trauma. The role of the dental influences in the development of the craniofacial complex is huge, because then once the teeth come in, they create anterior and lateral boundaries for the swallow, proprioception, that positional awareness of tongue and space. But the teeth also support the postural relationship between the head and the neck and the body. Like if you don't have enough mandibular vertical development, you still have a space issue. It's not just transverse, it's also vertical. We have compensations and functional asymmetries in the trigeminal region that can happen if either the swallow isn't developed properly or the dental occlusion isn't developed properly. And neurons that fire together, wire together. And that happens during the early stages of embryological development, where our cranial nerves and our brachial arches are developing. And as we develop the trigeminal neural circuits, most of us are pretty aware from our training that there's a motor division of the trigeminal nerve and a sensory division of the trigeminal nerve. But what's super interesting is this third division, which is the mesencephalic trigeminal nucleus, which has way more influence than we ever thought possible. I mean, I went into dentistry because I didn't want the responsibility of medicine, and we're sitting in the hot seat in the dental profession. So the mesencephalic trigeminal nucleus, you'll see it in the literature as either an MTN or an ME5. And while not yet fully understood, what we think at this point in time, it's a representation of a sensory ganglion that became incorporated into the brainstem during embryonic development. And it's responsible for unconscious proprioception from muscle spindles and the apical third of the periodontal ligament, especially in the premaxilla, and is essential in the process of receiving sensory information about tooth pain that helps prevent excessive biting that may break a tooth. So that's the jaw jerk reflex. That's the whole process of understanding what the NTI device does, the nociceptive trigeminal inhibition, because the anterior teeth have 4 times more receptor density than the posterior teeth, and how this mesencephalic trigeminal nucleus works, which means a little bit in force goes a little bit in front goes a long way compared to a lot of force that happens in the back if you're not able to get it anteriorly. So here's our 3 branches of the trigeminal nerve. We have V1 and V2, which are our first 2 divisions, which the swallow is directly affecting this anterior cranial base from the first two divisions. And then when we get the third division, that's our dental occlusal factors when the mandible comes to town, which can either stabilize or contaminate the input from the trigeminal nerve to the brainstem. And we are looking at in neurodevelopmental dentistry about optimizing function and a dimension of prevention. And there's a lot of people who are coming out recently and saying there is a lot more to this than what we thought. And one of them is John Remmers, rest in peace. He's talking about sleep and neuro. And the Andresanis for over a decade now have been dialing in the correlations between sleep and neurotransmitters and trigeminal neural circuits. And Dr. Nikki Mills is an ENT. She was trying to figure out why some of her tongue tie releases were successful and others weren't. So she went into research and she figured out a lot about the floor of the mouth anatomy from doing histological dissections, as well as understanding the role of the fascia and the neural components of all of that, which is invaluable to anyone who's doing tongue tie releases. And then there's Dr. Gabor Mate, who has spent his career as a physician understanding the role of adverse childhood events, first 1,000 days of life, on the development of the brain, especially when it comes to the development of addictions and disease, which is a neurological expression of development. And then we have all of those of us in the world of dentistry that are looking at the role of expansion with structural oral volume and how that affects things. So we have a few workable solutions when it comes to looking at airway function, right? But we do have to understand that airway is primarily neuroreflexive. It does have an influence on form and function. Obviously, the size does matter, but it's not everything. And then we have to also appreciate the fact that it's been years now that we've understood that CBCT, or three-dimensional analysis from a radiographic perspective, is not a really good metric for understanding the dynamic action of the airway. And then we have the big topic of tongue tie. And what you see is not always what you get, especially when you roll around in Dr. Mills' research and how fascia influences tongue function. And then we have our oral volume that we can always work on. We have our transverse, our intermolar distance, our metrics. The very common oversimplified approach is to say you have to have a width of a cotton roll in the mouth. But that's not always true. We have vertical dimension, which is another huge part of airway. It's not always intermolar. It's how much height we have in the bite as well, and preventing the development of a deep bite. And then we have the tongue as proprioceptive boundaries. And we have some intentions that can be actionable. We need to define etiology. What is the cause of our problems that we're trying to fix? What is the expression of the genetic and the environmental components to this? And we also have to look at ideology. I mean, when you know better, you do better. And we're always learning in medicine and dentistry. That's why it's called a practice. But there are some ideas that get really cemented in and they're hard to change. And that's why I want you to be open to changing your mind. We want to avoid oversimplification of complex conditions. Life is messy. Human development is complex. We can't just put a number on things. We need to have an awareness of all the literature, all of the research, as well as the politics that go along with that and the limitations of research on human beings, because there's no control variable for human development. And that's what Dr. Mate talks about, a biopsychosocial role of development. I want to bring up a term, and that has been developed to describe the modulating the neural circuit dedicated to controlling muscle function, especially in the treatment of disorders of functional, neurological, and craniofacial development. And I refer that as to neuromyofunctional. We're going to the boss, we're going to the manager, which is the brain, and saying, why are these muscles working or not working, especially with the tongue? Because if the neural circuits of the swallow are suboptimal, the swallow will be suboptimal as well. And then let's talk about the definition of neuromodulation, which is the alteration of nerve activity through targeted delivery of a stimulus. Could be electrical stimulus, could be chemical stimulus, could be touch-based stimulus, could be light-based stimulus to specific neurological sites in the body. And then neuroplasticity, which literally means changing minds. It's an adaptive structural and functional change to the brain. And neuroplasticity, it involves multiple different processes. It's just not a if this, then that. there's multiple different functional reorganizations that occur during this process of neuroplasticity. And I want to spend a moment in memoriam of Dr. Rimmers, who I love what he says about this, because those of us who have been in sleep medicine, and me as the president of the sleep board, when I read this, I'm like, thank you, Dr. Rimmers. And I'll just read it. Not every dentist, physician, or the ones that teach others appreciate the connections between airway and the neurologic factors. AHI, that is a failure. It just doesn't take enough of the evidence that's come out since 2000 into account. That's what the Intersonies are doing. So they're like, that's this podcast that he did. AHI and CPAP have disappointments. Can we do better? We can do better. And there's Dr. Gabor Mate, who I am so honored to say that he is speaking at our November event, which is a collaboration between the Synergy Academy and the ABCDSM, the sleep board, because his contributions to medicine and our understanding of how our early childhood development affects the trajectory for the rest of the life. And he's going to be speaking on his best-selling book, When the Body Says No. And we're going to be bringing in how important the oral complex is to the development of how the body can say no, or hopefully yes, if we get these neural circuits lined up early. And I'll tell you more about our November meeting later in the presentation. And as a society, we need urgent and innovative solutions because we're continuing to face more complex challenges, especially since COVID came to town. And Einstein said it best, we cannot solve the problems with the same level of thinking that created them. So I'm going to give you some more ideas. And as a profession, we should do our best to avoid oversimplifying things because, what we know, we get comfortable in that. And because, that's our tribe. That's what we do. And as a tribe, we like to tell everybody that we know what we're talking about, whether it's airway or tongue tie or expansion, whatever it is. But this quote is really important to understand. Oversimplifying is the first grave mistake we make when confronted by complexity. Overconfidence is the second. And there is a third. Based on our overconfidence and our oversimplified conclusions, we overreact. And sometimes people get defensive and they say, oh, that can't be true. Where's the research? And we need to look at all the data that's out there. And I found this on Facebook, and so I'm sharing it with y'all. There's this professor that's wearing this shirt, and it says there are two types of people in this world. One, those who can extrapolate from incomplete data. And then the caption says, so two of my classmates just asked our professor if his shirt is missing a second part. That's the point. We need to be able to extrapolate. But then Helen Keller quotes that people do not like to think. If one thinks, one must reach conclusions. Conclusions are not always pleasant. And I'm going to be asking you guys to put on your thinking caps today, because when we're dealing with these precious patients of ours, they deserve us to think our way through it. We're getting it. We do understand structural metrics, which would come a long way in dentistry from when I graduated school. I mean, this wasn't even a thing back then, back when the dinosaurs walked the earth 30 years ago. Then the functional awareness is also coming on, which is fantastic. But we still, as a profession, don't have conclusive evidence to support full diagnosis of etiology for many of our patients. And our limitations as providers are often found in our blind spots, which we all have them. And that's what George Cantor said, a false conclusion once arrived at and widely accepted is not easily dislodged, and the less it's understood, the more tenaciously it is held, and usually that's held in our blind spots. So I'm going to ask you to expand your minds and not just your patients' mouths. So how can we be part of the solution since we know there is a problem? We can change the environment in which the neural circuits of the trigeminal region are created. We're functional mechanics of the craniofacial environment. We have so much power in our hands. And the second is we can encourage the maintenance of the neural circuits through positive proprioception to avoid nociception, which is pain, avoidance, and the compensations that come from pain. Then we can create the environment for neuroplasticity, literally changing minds through therapies specifically designed to improve functional capacity and human resilience. Back to the cartoons. How are we going to do that? We have many opportunities, but the two we're going to be talking about today are touch-based therapies through mechanical transduction and light-based therapies, which are optogenetics, which include OraLase and BabyLase. So mechanical transduction can be done through dental appliance therapy, can be done through surgical approaches, functional and manual therapies. And then there's optogenetics, which is the 1064 nanometer laser therapies. And that creates the best environment in my professional belief at this point in time, after doing all that I've done, to create the most positive forms of neuromodulation. Optogenetics is a biological technique to control the activity of neurons with or other cell types with light, and it is different than photobiomodulation. Because at this 1064 wavelength, which is unique to just a few lasers that have been developed to provide BabyLase and OraLase at this point in time, this depth of penetration is very unique to this specific wavelength, and it goes down to the neurovascular layer as well as to the muscle and the fascia, which is how we get our most efficient optogenetic modification. The reason is because there's less sensation of heat from superficial tissue, so we can push in more energy to get more done. We have the creation of a thermal response to loosen the fascial restrictions. Kind of like when you get a deep tissue massage and they have to push and push and push and push and push and create frictional forces to be able to loosen those fascial restrictions. Imagine doing that just with a nice warm little light and not having to touch them, especially the floor of the mouth. No one makes any friends by rubbing someone's sore floor of the mouth, because with this 1064 wavelength, we can get to the level of the neural vasculature. And other wavelengths just can't get there. They can, superficially warm things up. They can get some circulation. They can help patients feel better, but they really cannot get to the depth of penetration to get the magic done that we're getting with OraLase and BabyLase. And OraLase and ALF Therapy were created by Dr. Derek Nordstrom. And what OraLase is, it's a neurologic reset and integration. It kind of turns on the lights so the brain and the body can see each other under better circumstances. In other words, it heals the tissue by making it feel better. And then it tells the brain, we're cool now. We can have a makeup after we've had the breakup of having a traumatic damaged tissue response. But if we don't even have a damaged tissue, we can still adjust the dimmer switch to improve neural tone. For example, I would like to think of myself and categorize myself. I identify as an overachiever. I did years of orofacial myofunctional therapy. I could not do an effective cave. And when I went to the Make the Connection course, Mary Billings, Diana Davidson, all the people there watched me rode the struggle bus really hard for 2 days. And on the third day, I had the osteopath that I was with take me out in the hallway, get the laser, and do OraLase on me for the first time. And I was instantly able to do my posterior palatal seal. And then everyone was like, me next, me next, me next. And we treated about 12 or 13 people that weekend, all had increased lingual palatal seal range of motions immediately without any surgery, and with a lot of other benefits that go along with it. We're integrating cranial nerves to enhance neurological midline awareness. We're instantly relieving restrictions that is caused by immobility and tissue damage at the floor of the mouth and the base of the tongue, by warming that tissue up and getting hyaluronic acid, which is supposed to be a gliding lubricant between the muscle and the fascia that sometimes becomes a restriction, more like glue instead of goo. So we warm that up and we get it moving, and we can literally increase range of motion dramatically in one appointment without having to do surgery. We're increasing blood flow to allow lactate and sore muscles impeded by those fascial restrictions to also mobilize, because we can get deeper into the muscle with his 1064. But the real magic is we're activating the mitochondrial function in the neuron to create metabolism in the connective tissue, as well as just in that whole area that's been damaged underneath the tongue and in the cheeks and the lips as a compensations from the swallow. And then what is BabyLase? BabyLase is not, in my practice, the same as OraLase. So most of the people who have learned about infant feeding and training know that at the age of 2, the adult chewing pattern and swallowing pattern should be in place by that period of time. So I divide my laser therapies, and that's why I developed BabyLase, because it's an adaptation of OraLase as applies to the unique needs and challenges of our most vulnerable and our most adaptable in ages 0 to 2. The intention of BabyLase is to address the effects of birth trauma by normalizing the primitive reflex and cranial nerve system. Back to that cartoon with the tongue and the brain. They need to be plugged in, but they also need to be understanding that the babies that are being born, whoever designed the birth canal didn't go through it, but whoever designed it also knew what they were doing, because going through a normal, natural birth process is a series of downloads and uploads for that baby. And if they don't have a normal, perfect delivery process, we can give that back to them through the miracle of BabyLase. And we're improving neural tone for both the hyper-responsive or the high-tone baby, the ones that are coming in hot that can't regulate themselves, as well as the low-tone baby, because that's how BabyLase was born. I had a very low-tone baby. None of the feeding reflexes were on board. No gag, no suck, no lateralization, no palmar grasp, hypo-responsive Moro. It was like the lights are on, but no one was home. The parents had already had another child where I had a similar presentation, and they said, well, let's try a tongue tie release. And he ended up in the PICU for 2 weeks, and they didn't want to do that with this baby. So 3 sessions of BabyLase, and he was back on the breast and thriving. So once you see that, you can't unsee it. And that's where my life changed. And that's where BabyLase was born. We're integrating those cranial nerves in these little babies to enhance neurological midline awareness, which is important for those who know how a baby's supposed to develop in tummy time and all the things that neurological midline awareness does for that developing brain. We're also instantly relieving restrictions associated with that densification of that hyaluronic acid underneath the tongue and the floor of the mouth, instantly, comfortably, and very effectively. We're increasing blood flow to allow the lactate and the sore muscles to go away, just like we did with OraLase, and then we're also activating the mitochondrial function for the connective tissue and healing. I like to think we're on the cutting edge of not cutting. We can be utilizing the OraLase and BabyLase to non-surgically and comfortably improve tongue function to assess if additional interventions, including a surgical tongue tie release, are necessary and appropriate and done with the appropriate treatment sequencing. It allows the patient to gradually integrate the changes accomplished by simultaneously improving both form and function at the same time. That also promotes conservative care while utilizing an evidence-based approach to comprehensive wellness. The concepts that we talk about with OraLase and BabyLase and ALF Therapy and Neurodevelopmental Dentistry are not only the tongue, but also the muscles that are used as a compensation for them. So the orbicularis oris, the buccinator, and the superopharyngeal constrictor are the only ring of muscles that will take the mandible backwards to cause that deep overbite. So the lips, the cheeks, to the superopharyngeal constrictor, which is actually a circular tube of muscle that is around the airway. It is our airway corset. And that's the only thing that'll pull the mandible back. And if there's excessive tone or tightness and pain in there, the mandible won't grow forward. So we're addressing that specifically through our techniques. We're also looking at the floor of the mouth musculature as a compensation for a dysfunctional swallow, as well as the masseter and the muscles of mastication, which are often called in to compensate for a dysfunctional swallow. We're taking a comprehensive approach to all of this by looking at the role of retained primitive reflexes and adverse childhood events with a whole person, whole lifetime neurodevelopmental perspective, by understanding that if we don't get it right early on, we're going to have a child grow into an adult that is going to have potential challenges with pain, sleep, facial development, and airway homeostasis. And then this term called limbic hypervigilance, which is the constant worry, the background noise of trauma, especially when that trauma was created during infancy in the first 1,000 days of life. Because life is a series of lessons that we can either learn the easy way or the hard way. And if the normal developmental process is interrupted, there will be a compensation and an adaptation for that we want to try to do our best to help that patient overcome the challenges. So we want to create competency as well as addressing compensation. So it's not just about getting the tongue to work better. It's understanding how those neural circuits of the swallowing mechanism can be modified through neuromodulation to allow the proper muscles to strengthen and the overworked muscles to relax. Because you guys know what it's like when you have a coworker that's not doing their job and you have to work 3 times harder, you kind of get a little sore about it, right? Well, so will the compensating muscles of the tongue. And we have to look at the way that the tongue is actually supposed to work. And the posterior third elevation of the tongue is supposed to be coming from insertions above the tongue, the palatal glossus and styloglossus, and not those from pushing from below, which is going to be your floor of the mouth fascia and mylohyoid muscle. And examples of what OraLase and BabyLase do from a normal everyday kind of way to explain it is if you have a patient who has a bad cardiac rhythm, they use electricity to reset that in an AED or an automatic external defibrillator. With OraLase and BabyLase, we're using light to be able to reset the tongue for swallow function. Then during our basic life support, when you're using an AED in between shocks, in between treatments, they say continue to do compressions, which is in this analogy with the tongue. That's when we need to keep motion and moving in that tissue that's now able to move because we turned on the brain and we took away the pain. In this analogy, it's going to be your manual therapies, your orofacial myofunctional therapy, your motor rehabilitation therapies, your chiropractic, your osteopathic, your physical therapy. Because once that hyaluronic acid is moving, we need to keep it moving. But in the heart analogy, if a patient cannot maintain their own cardiac rhythm, they have to give them a pacemaker. And this analogy, if a patient cannot get the hints that we're throwing down for them of how the tongue is supposed to work and they need a constant reminder, there are dental appliance therapies that are specifically designed to remind that patient where their tongue is supposed to be so the process can come to fruition and we can have a successful swallow conversion. In my practice, that is ALF therapy. And there might be others that are out there that can possibly complement the development of a functional neural circuit. And there's a lot that actually corrupt them and hold the tongue down and prevent that development of a neural circuit. So when we talk about this in the ALF evolution course, that's how we design our appliances specifically for the needs of that patient's clinical presentation and phenotype. Because the ALF is a prescription-based appliance. A lot of people think it's just one appliance and it's designed the same, like Frank's Red Hot Sauce, where you can just put that on everything. It is not. That appliance that you see in the little logo right there might look different on every single patient, and that's what we teach in the ALF instruction through the Synergy Academy. Oral motor therapies can be amazingly helpful or unintentionally hurtful, like it was in my case. I trained myself for years to be able to do a cave elevation the absolutely wrong way. And it hurt me. It created stress for me. I was so sore, but I didn't understand it at the time. And I just didn't know. And so the skill and the level of understanding of the orofacial myofunctional therapist providers are a critical aspect of successful therapy in neurodevelopmental dentistry. So when the recommended movement patterns complement and don't corrupt the development of functional neural circuits, they're an asset. However, when the habituation of movement patterns performed without regard to assessing and addressing compensations and the requirements of the autonomic nervous system regulation, which is the balance of fight and flight and rest and digest that make us feel either safe or not safe in this world, oral motor therapy can be a liability if it's done without an awareness of the actual more important things than tongue positioning. This research here may lead to why some of the medical and even in the speech and language pathology community have problems with oral facial myofunctional therapy in the context of treating oral facial myofunctional disorders. So this literature reference talks about how tongue and lip strength and endurance in healthy young adults with and without oral facial myofunctional disorders. And the purpose was to examine whether there was a difference in the tongue and lip strength between subjects with and without OMDs, as well as to look at quality of life. And the results of the study, there were no differences between the three groups in the isometric pressure and endurance. So the conclusion was, although oral facial muscle strengthening is commonly part of ONT, current findings suggest the superfluidity, which means an unnecessary or excessively large amount or number of something, of these types of exercises in the treatment of OMDs and healthy young adults may indicate the need to focus on awareness and rehabilitation of pathological functions in these individuals. I had a pathological function. I didn't know it because I was not elevating with the proper muscles and I was creating pain. So this research goes to show that too. In this research, they had a group of people, half male, half female, mean age of about 20 years, and they asked them to have different periods of time where they had their tongue in a baseline position, a tongue wherever they wanted to be, floor of the mouth or roof of the mouth. And they indicated that when the patient was putting their tongue on the roof of the mouth, they had more activity in the temporalis and suprahyoid muscle regions, as well as a reduction in heart rate variability, which means stress, when the tongue was on the palate compared to the floor of the mouth. So their conclusions were instructions to place the tongue on the roof of the mouth are not instructions that promote relaxation, but instead promote pain and stress. And that's not what I thought it was going to be. I thought, put the tongue on the roof of the mouth. That's how you make successful human beings. That's what it's going to take for me to be successful. And I was actually stressed out and I felt like a failure as a human because I couldn't do what other people could do. And now I know why. My first OraLase session, I was able to do it and explained everything to me. When people are taught to lift heavy things, they're told to use the muscles that they're supposed to use, which are going to be their leg muscles and not their back muscles. But I admit I'm a cheater here too. And sometimes I'll hurt my back because I'm not having proper lifting techniques. So if a patient is using a compensation to perform an activity such as tongue elevation like I was, they're strengthening a dysfunctional pattern by exercising into it, therefore creating really complex fascial and neurological restrictions. So where did things go wrong in development where I developed a swallow that didn't support me? And how could we make them right? Well, early childhood trauma, early stages of development, certain events are created to occur to support the maturation of our growing bodies and brains as well as our ability to regulate ourselves. However, there's times that derail that plan. And we are living in an unnatural environment, expecting the miracles in nature to sustain us. And we have to learn how to embrace natural principles and as well as the technology that's been created to help us move through these problems that we had early in life. Because I love this quote from Gabriela Mistral. Many things can wait, the child cannot. Now is a time that his bones are formed, his mind developed. To him we cannot say tomorrow. His time is today. And we have a rising number of neuropsychiatric disorders in childhood that come from autonomic nervous system development. And that is affected by both the developmental limbic system, which is our emotional system, and our ability to be plastic or change our minds about what our environment is giving us. And that can be preconception, fetal development, infant development, and child development, and all can be stress and environmental influences. And this slide on the left does show exactly what my mind is like, because I had a lot of early childhood trauma. My mind is like my internet browser. I have 19 tabs open, 3 are frozen, and I don't know where the music is coming from because I didn't have words to describe where my trauma was coming from when I was a year old. But my brain is still trying to figure it out. And that limbic hypervigilance is one of the things that will create potential issues down the road. And you're wondering, how does that affect the swallow? Because the study that I just talked about said that people will calm themselves by putting their tongue on the floor of their mouth. That's how I got through. That's how I managed myself in my limbic system. And it was a compensation, but it was what I had to do to get through what I had to get through. So we're going to address the cycle of dysfunction in the circle of life. We're going to look at both the chicken and the egg, the potential origins of the disconnection, and how we can strive to reconnect them. And we're doing that all day long, every day, in the offices where we're offering OraLase and BabyLase. And let's talk about what a restriction is, an act of limiting or restricting. And that could be a lack of understanding of the different types of restrictions that are out there, or it could be the act of keeping something within specified bounds by force if necessary, and that could be a structural limitation of freedom, or oral volume, or fascia. And another definition of restriction is a principle that limits the extent of something, and that could be a dysfunctional neural circuit. Let's redefine restriction for a moment. If you're sitting at an intersection and you're the 4th car back, let's just say, the light turns green, but car number 1 doesn't move. You still have a restriction. You still cannot go through that intersection without causing a lot of damage. Think about car number 1 as the brain and neurological function. Retained primitive reflexes, cranial nerves, all the things that are inside the brain, like literally it's all in our head. Because if we don't have a signal of safety to go forward from a neurological function, the fascia in car number 2 is going to be tight and restricted, especially from a retained primitive reflex called Moro, which is the startle response, which will keep tongue posture low and head and cervical extension position. And guess what the tongue is made of? Fascia So if the fascia is not moving, neither will the tongue. And car number 3, you can honk, you can bump into the bumper of the car in front of you, but you're still not going to get there until you understand the flow. And think about the fourth vehicle back as a bus. And that bus is the cranial vault. And the passengers that are inside are the pretty little teeth that I went to school to learn how to treat. Tongue was my enemy in dental school. Now it's my frenemy. It's my friend. It's how we make people work, but it's still hard to overcome unless you have tools available to do it. Primitive reflexes are sitting in the driver's seat of neurological function in car number 1. They're intended to be protective, but if they're not appropriately expressed, they can literally result in brain cell death from high corticosteroid, like glucocorticoids, the stress hormone. So when we have fear paralysis reflex, it happens in utero. Mom gets stressed out, baby will shut down. Then it turns into moro, which is a little bit more advanced, where the body will stay rigid, not shut down, but will stay rigid with stress, which is fascia. We have the root reflex, which is supposed to come on at birth and go away at 3 to 4 months. Palmar, grasp, 5 to 6 months. It is a feeding reflex. We have the suck reflex, which starts in utero, goes away at 3 to 4 months, which is why we don't want pacifier use to go on much beyond that, because then it'll be a habit instead of a way to regulate autonomic nervous system. And then we have our gag response, which can be in the anterior third of the tongue, but is not appropriate. And also, you should not be able to stick your finger down the posterior pharyngeal wall of a baby or an adult and have no gag reflex. That's when it's inappropriate. So when we evaluate babies and we evaluate humans, we need to look at these primitive reflexes as something that's supposed to show up and go away at a certain time. If they don't, they can be a problem in overall treatment sequencing. And then this is the real kicker to me. Did you know that the emotional and physical pain aspects of being human activate similar brain functions? So in other words, they had a group of people that had gone through breakup with romantic partners, and they did baseline studies like psych test and a follow-up psych test, and they gave half of them non-steroidal anti-inflammatories. The people who took the painkillers, the non-steroidal anti-inflammatories, actually had a more effective recovery from the psychological impact. So we have one pain pathway for emotional or physical pain, and we have to be able to understand that, especially when it comes to tongue function and how we compensate for that stress. And the neurological aspects of emotional regulation, as well as reflexive feeding, are the primary reason for OraLase and BabyLase to exist, because we're evaluating the impacts of gestational and birth trauma by stimulating the C fibers, proprioceptive fibers, to positively influence autonomic nervous system regulation, which sounds really complex, but it's not. When you think about babies that aren't held, they don't thrive. You can feed them, but they don't thrive. They need touch. They need human touch to be able to succeed. And we all do. And that's what we're accessing with OraLase and BabyLase at very high levels. We're also stimulating the cranial nerve system to improve the neural circuits early in life to get them functionally developed. We're accessing the limbic system through inspired sequencing, which is we go into much more depth in the courses. And we're stimulating the vagal nerve to upregulate the parasympathetic nervous system. But assessment of that primitive reflexive system is critical when looking at the concepts and the approach of neurodevelopmental dentistry. So the primary goal of BabyLase is to normalize the feeding reflexes as the goal of treatment in an infant. The function of the oral neuromusculature will be impaired without the activation of the neural circuits of feeding. And therefore, there's going to have not a full range of motion if there's a fascial restriction as well. And the primitive reflexes system is just as or more important than any visual assessment of a tongue tie, as proven by the emerging literature. And if you guys want to learn more about the primitive reflexive system and how it impacts oral function, you can go to the faceplace.us, which will take you to a companion site, which is solvelearningdisabilities.com, to learn a lot about the primitive reflexes. In our OraLase and BabyLase community, I like to refer to what we do as a care release, which is an acronym for careful assessment and restriction elimination. And that means all restrictions to function, not just the ones you can see. So we discern the different type of restrictions. We make decisions about treatment sequencing by using all the tools that we have available, very specific techniques that are taught in depth in our courses, and using exceptionally specific technology. And right now there's only 2 delivery systems we know that can provide that technological advance to offer the miracle of light. And that miracle of light is how we're shaping the field of neural stimulation and neuromodulation. And this is the research that supports it. And there's more research that supports it. Of course, this is a parallel to electrical stimulation of cranial nerves, but we're doing the same thing with light, because when we're neuromodulating through OraLase and BabyLase, we're accessing the skin, which are direct afferents to the brain, basically plugging in the skin or the tongue to the brain. And what's so cool is by leveraging those unique features, we are able to target a constellation of brain regions and symptoms and functions that are in line with modern neuroscience. And basically, what we're doing with OraLase and BabyLase is an intervention design framework based on driving cranial nerve pathways, which are in turn linked to specific higher cognitive processes like neuroplasticity and neuromodulation, so we can actually change these neural circuits and improve function at the cellular level and at the neurological level. So when I was talking before about hyaluronic acid, a lot of people, especially women, think it's just something that's going to make our face lotion more expensive. But what it really is these blue lines interspersed in between the deep fascia and the muscle fibers. Now, when you look at the next picture, this is what Nikki Mills had created as part of her research. And this cartoon shows the green line as being the fascia as part of a submucosal fold, where the red line is mucosa, and then this is the muscle underneath it of the genioglossus. So the following article on the right very clearly says that if the epimysium of the genioglossus is disrupted, the surface of that hyaluronic acid glide that you're seeing on the left is obliterated, which means if the muscle was touched, there is now a restriction. There is a scar under that tongue, which is why people are using Kenalog and a lot of things these days to try to deal with a scar, but it could have been avoided if they wouldn't have gone in the muscle. So in other words, if we take one step forward as we release a tongue tie, we might have 2 steps back if we create a different restriction, because this can't be undone. So Nikki Mills, God bless her. She's like, I got to figure this out. And she said the lingual frenulum is a folded fascia, not a band. It's not composed of connective tissue fibers that have an anterior-posterior orientation, nor is it a discrete quarter band. In contrast, the fascial fibers that form the frenulum have a basket weave orientation as it crosses the midline. And then she said the diagnosis and classification of, in quotes, posterior tongue tie is based on a construct of a midline submucosal band. That concept was not supported by her dissections and her research. So when I was asked to do a presentation for a airway summit overseas, I was surprised they asked me to go over this, and I knew the research was just great, but they said, Dr. Tenholder, can you describe this drawing? And I said, okay, I'll do my best. Red line, mucosa, green line, fascia. Some tongue restrictions are going to be purely mucosa. You can see through it. Pretty, safe in assuming that. But others you can't. They're more dense. You can't see through it, and therefore there might be fascia. But you also can't see because it might be muscle. And I just showed you what happens when you cut muscle. So I encourage everyone to go through her research. She has one for a neonatal freedom, and she has the adult. And then this podcast of hers, 2020 Baby on Apple Podcast, is really a good one to listen to get a different perspective on the impact of surgical releases. And then this is kind of a big deal for dentistry. Remember I said I didn't want to go into medicine because I didn't want the responsibility? Well, now they've done research on asymmetries and occlusion. And basically through this article, it says that it is known that asymmetries in the trigeminal and vestibular signals induced by malocclusion are detrimental for performance, and their elimination by occlusal correction improves cognitive performance in patients affected by Alzheimer's disease, as well as in normal subjects. In other words, when you sit down in a restaurant, you have a table wobble. That's kind of irritating, right? Everyone's going to be like, give me a napkin. I got to shin this up. It's going to drive me nuts. Well, what if that asymmetry in the trigeminal region is there? Imbalanced bite, imbalanced swallow, cranial strain. It's a lack of balance. They were able to reverse Alzheimer's by bringing balance to the trigeminal system. Imagine the power that we have catching someone early in life and understanding this concept. This is the hyaluronic acid liquefaction I was talking about. It's called a FLIR image. So it's a temperature sensing image showing that we're reaching 40.3 degrees. And once you get over 40 degrees Celsius, you start melting hyaluronic acid. So that is the actual real life in my hands data to show that that is how we're releasing tongue restrictions non-surgically. And we're addressing not only just that, we're addressing many more. And in the RestOralase course, we also teach another wavelength, which is erbium YAG, which can neuromodulate on an even higher level, but can also shrink the collagen of the soft palate so it's not as redundant and not as floppy, but it's not killing it. It's not heating it up. What it's doing is bringing it back to life. It's telling the muscles how to elevate the palate while having a gentle kind of fountain of youth going on in the soft tissue of the palate. It's very effective. But more than that, we're addressing the neural circuits in the first 1,000 days of life to integrate tongue and airway function from a neurological perspective. And we're getting to know a little bit more about how important that is. And Dr. Gabor Mate, adverse childhood events. We have the dopamine pathways. We just think dopamine was the reward, but it's actually the chase. It's the neuromodulator of connection. It's vitamin D dependent. So if you don't have good vitamin D levels, you can't make dopamine. If you can't make dopamine, you can't connect neural circuits. So we need to understand our vitamin D. Then we have Dr. Huberman and Schubiner talking about the role of dopamine in neural circuits. Carl Deisroth doing amazing work on optogenetics. Dr. Ghazal and Andresani on the roles of inflammation and neurotransmitter depletion in the etiology of sleep disordered breathing. Nothing to do with intermolar width. Nothing to do with the size of the airway on the CBCT. Then there's Nikki Mills. And then once again, I'm going to say it again, even though it's repetitive. Not every dentist or the ones that teach dentists and others appreciate the neurologic factors. But we do. The Andresanis. This is what they came out with their article on sleep apnea pathophysiology in 2023. Despite its name, obstructive sleep apnea is not caused by an airway obstruction that prevents breathing. What it is, they concluded that a dysfunctional mesencephalic trigeminal nucleus may be incapable of activating the neurons in the ascending reticular activating system, and that will lead to sleep apnea. That's the etiology of sleep apnea, and it goes to the trigeminal neural circuits. So that's a little challenging for someone who's been, studying sleep medicine and trying to help my husband and thinking, okay, sleep apnea tolerant mandibular advancement appliance. But the guy who developed the mandibular advancement appliance was the same guy who developed ALF and OraLase, Dr. Derek Nordstrom. And he knew even back then, over 40 years ago, that the mandibular advancement appliance, it might just be a neural hack. And if you know how to do it right, you're going to get better results. Something to think about. So OraLase facilitated neuromodulation connects neural circuits, removes the fascial restrictions, it reduces, I'm so sorry, it reduces pain and inflammation to improve both craniofacial pain and sleep disordered breathing. So the Andresani said they hypothesized that obstructive sleep apnea is the result of neurotransmitter deficiency, which is why we're getting results with medications like tirzepatide and reboxetine to address sleep apnea, and not just expansion and not just a tongue-tie release, because correlation does not imply causation. If you look at this little bird that's sitting on that fence, he didn't bend it. Looks like he did, but he didn't. So the size of the airway may not be causing obstructive sleep apnea, because this is the research that shows that healthy humans that have a narrow upper airway can actually neurologically control their airway, but same size airway with sleep apnea patients. They have a narrowed airway as well, but they don't have the ability to dilate their airway during inspiration. And that's the difference. So it's a neural control, and it's not as much about the size as what you do with it. And this makes me think of this Far Side cartoon on the bottom where the Midvale School for the Gifted. He thinks he's really smart. He's in a gifted school, but he's pushing on a door that obviously says pull, which we've all done. And we've all not known the neural control of the airway because it's not part of our traditional training, but it is a huge, big deal. So what if we can measure it? What if we could literally, through our patients' bodies and clinical assessments, figure it out in less than 2 minutes? we can, because the brainstem is a breaker box. We're making sure the power is on, and we're learning how to be able to understand the importance of those neural circuits. And that's what neurodevelopmental dentistry is. So Kenny Rogers said it best: know when to hold them. That's where we're going to have our successful treatment outcomes. That's awesome. We won. Know when to fold them. We all have them. We all have our treatment failures, that things just didn't work the way that we wanted them to. Know when to walk away. What if there's more that can be done though? Like, what if you can figure out there's something else you can do to complement maximal medical improvement? And what if it's in this neural circuit thing we're talking about? And know when to run, because there's times that we didn't do the right thing, like the tongue tie release, and now there's a restriction because we didn't have optimal treatment sequencing. But we can figure it out and do better next time, because that's what medicine and dentistry is. It's a practice. We're learning, we're growing, we're applying technology and techniques to help our patients. Potential solutions can be found in neuroplasticity to address obstacles as soon as they're identified. I have a 9-week-old grandbaby that I am treating because she had birth trauma. I mean, that's life coming back full circle. The instructor turns into the care provider, and it's amazing to see what this can do. And I am so grateful. I think that's why I developed BabyLase, because this baby needed me just as much as the other ones did. Neuromodulation. We can implement therapies intended to develop functional neural circuits on purpose, especially in the trigeminal. And then we have our neural circuits to get 5 to thrive through improved swallow and occlusal force vectors. And neurodevelopmental dentistry has a positive and intentional influence of the neural circuits of the head and neck, because that affects oral function, sleep physiology, and our treatment outcomes. But then everyone says, oh, where's your research? The answer is everywhere, every day. If you're looking for the literature references to support what we do and we teach at the Synergy Academy, it's on our website at the references and resources page, including those that are in this presentation. So what is evidence-based medicine? Where's the research? It's everywhere, but you have to look and be discerning, because research is going to be limited by clinical equipoise, which means a genuine uncertainty in the expert medical community over whether a treatment will be beneficial. Half of what we know in 10 years is going to be disproven as what we needed to do at the time, just because we continue to grow and learn. So who is an evidence-based provider? Those are clinicians who apply the wisdom of academic research that happens in an academic setting a lot of times to everyday patient care based on their observations and experiences. And this pretty much describes me as an evidence-based provider in the front row. However, there are people back in this third row saying, where's your research? So we're going to go over what evidence-based medicine really is. It's the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. It integrates clinical experience and patient values. It requires new skills, literature searching, and how we evaluate the evidence in our practice. And it's lifelong, self-directed, problem-based learning in which one caring for one's own patients creates a need for clinically important information about diagnosis, prognosis, therapy, and other clinical and healthcare issues. It's not a cookbook with recipes, but its good application brings cost-effective and better healthcare. And once you've been cooking for a while, you don't need a recipe. You just look at your ingredients, you put it together, and you figure it out. You make it work. And that's what I've been doing. I've had to figure out my direction through my career, because I started as a very traditional expansion, did it on my daughter, screwed her up, didn't know that she was not one of those patients that should have had structural expansion. And then I had to say, okay, what's more? What more can I do? So then I was 1 foot on the boat and 1 foot on the dock as I was looking for answers for my daughter. And there are people on that boat who'll be like, oh, no, don't get on the dock. It's scary out there. We have a tribe in this boat. We got to believe that everything we know is inside this boat. But my magic I found on the outside of the boat. And I want to share some of those stories with you. This little girl's name is Emery. She got her ALF and she had condylar hyperplasia. I mean, very, very complex case. And I didn't even start treating the structural things, but I got the ALF device in her mouth and she started feeling immediately better, and her whole body strength, her improvement in schoolwork, sports, overall behavior. Now, these are her words. These aren't mine. She has ADHD, but with an ALF, her hyperactivity levels have gone down. Focus is increased. This is an expansion. This is an opening of an airway. She's also grown 3 inches with it in. And each time we improved her strength, sleep, and focus. And now she is in phase 2 finishing. And now her siblings have received their ALFs. And she likes the fact that her sister is calmer also, like a lot. And then her friend, who was both Emery and her friend Samantha and her sister Amelia were adopted from an orphanage in South America and had some pretty, challenging obstacles to overcome. And they all got their ALF and they're doing amazingly well. And this is her quote and how she described me. It's always funny to have someone, do what you say. The ALF is like a playground in your mouth, equipment, many exercises, such as spinner bead and trampolines. The ALF appliance has helped my family immensely, and I'm certain will help others too if they give it a try. That's not expansion. It's just neurodevelopmental dentistry. But they didn't tell me the story about Evan. So this is the parent's biological child. And this is mom. She said that it's an absolute must that I share this with you because 2 years ago, Evan started worrying, having a lot of anxiety, fear on a daily basis, stress, body fatigue, and they've done so many things to try to make it better. His personality was changing and causing him to have extreme fatigue, to rest all the time, too tired to play, worn out after short bursts of activity. And before that, he had always been a very active child, very, very much of a busybody. And everyone was truly worried about him, but they didn't tell me any of this. I just said he has a little deep bite. Let's go ahead and since his sisters are getting treated, let's go ahead and get an ALF in him. And they really didn't think that he was going to need it as much as the sisters did, but he went along for the ride. Their astonishment came the morning after ALF placement. Just 16 hours later, he woke at 6 a.m., ran into the room to say, "Good morning, I slept great, I'm ready for the day." Then he began running around the house, talking in stories, planning all the fun he was going to have. He took him on a hike, and then after he wore them out, he brought him back. They got in the pool. His joy and energy exudes all day. They have their son back. This is the adventurous, life-loving boy they had known for 8 years and missed for the last 2. And truly the only change was the brain balance that the ALF provided. We didn't even consider as a possible effect of it. And that is why I do what I do. Because when I gave this family their child back, that reminds me of my whys behind the wires. So miracles are everywhere. Be one. This is Emery. She grew through inches. You can tell, there's still a lot of growth to go. But this is her friend Samantha, who was in a Herbst and had like huge expansion. Took her out of it. They weren't unsuccessful with growth hormone therapy. And all of a sudden she started growing and speaking and playing football with her siblings in the yard she wasn't able to do before. There's Mila, who's also doing great, who Samantha likes a lot better with her ALF than she did without it. And there's Evan, the little boy whose family got him back. And it wasn't airway development. It was neurodevelopmental dentistry, ALF and OraLase. So if you're interested, you want to learn more about what we're talking about today, go to neurodevelopmentaldentistry.com. There's also the Synergy Academy YouTube channel. We have a lot of information on the Sleep Board website at abcdsm.org. You can learn how to do those assessments. It's a 3I course in November, and then the Changing Minds meeting with Gabor Mate, Christy Gatto, myself, and Stacy Becker, and Lieutenant Colonel Dave Grossman is on November 21st and 22nd. And then we have our courses through the Synergy Academy. So thank you for listening, learning, and being willing to change your mind.
Wow. Oh my gosh. I think that most of we're feeling like me right now. There's a very thoughtfully organized presentation. She's amazing. Absolutely. I mean, we are freaking out. This was incredible. Thank you. Thank you. Thank you.
You're welcome.
I have many questions. However, I'm going to be respectful of your time, and I know people also have tons of questions. So I'm only going to ask a few. And I'm going to start from the bottom here, since you just mentioned the Herbst appliance. For those who do not know, why is the Herbst appliance usually recommended by some orthodontists? What is it intended to do? And the second part of that question is, what are the negative compensations of that type of treatment, of the type of appliance?
So I'm going to put a disclosure on this that I'm not an orthodontist.
Okay.
Could have been, didn't want to be. The Herbst appliance, in my understanding, is used to correct a class 2 malocclusion, to
Mhm.
advance the mandible using some pretty rigid mechanics. They're metal based. So what I have noticed is that some patients who aren't very resilient and don't have good motion of the bones of their head, the Herbst appliance can cause some pain and dysfunction. So I've had several patients that I have taken out of a Herbst, and when I did and put them in an ALF, they were able to thrive when
Yeah.
before they were not. They were just restricted. Kind of like trying to dance with someone stepping on your toes. That's
Mhm.
not everyone, but that's the best way that I can describe it.
Perfect, thank you. And I asked you because I noticed that a lot. Several patients come to me, and a lot of their issues started after they had the Herbst appliance whenever they were younger, or those who are recommended that type of appliance while they're seeing me. I usually, of course, step away, and I'm like, let the orthodontists do their thing, but I usually notice that they kind of stay locked. I don't see growth during that period. So that is interesting. Thank you so much for sharing that. And how is, I love that you mentioned ALF. This was not extension, it's way more. You know, the ALF does so much more. So if a child comes to me and they are having some of these issues that we mentioned in this talk today, however, clinically, it doesn't look like they need expansion, could they still be an ALF candidate?
I would like to say that I don't know who wouldn't be an ALF candidate, but it depends on the patient's desires, the provider's skill level, and the provider's training of what they're capable of doing with an ALF. Because I acknowledge that there's a lot of misunderstandings about
Mhm.
ALF and different instructors and how it was done and using it incorrectly, because the ALF is an organic expression of growth. The wire isn't doing the growth, it is the tongue that is doing it, which is why OraLase was developed. Because if the tongue's not able to create energy in the ALF that does all the magic, then it's not a real ALF.
Wow.
It's a fake ALF, or it's an improperly used ALF. And that's where some of the complaints of ALF have come from, or it's just tipping teeth. Well, it doesn't, when you're using it properly, it doesn't do that. But that's where people have had the misunderstanding. And that's where I love to be able to get out of there. ALF was never designed to be an expander in its own. It's
Mhm.
allowing the body to expand itself at its own rate as the body and brain can grow together and improve function and form simultaneously.
So are all your ALF cases also simultaneously doing myofunctional therapy?
Most of them are. What's so nice about ALF is that it does a lot of it on its own.
Mhm. It
So
brings the tongue up immediately if you have something up there.
you can't not. Like if anyone has burned the roof of their mouth, like on the incisive papilla with pizza and they have that little dangly piece hanging out, you know that your tongue is going there. So it helps with tongue targeting. It helps the swallow conversion. And a lot of patients that come to see me for ALF that have been in speech therapy for years and they could just not get there, ALF and OraLase, and all of a sudden they're saying they're ours and they have the full range of motion within 2 weeks. So it is the easy button.
That's incredible. How does this neurodevelopmental approach that now you advocate influences your dental sleep medicine training?
So it's everything. And that's the thing about being the president of the sleep board, because sleep is changing faster than you
Yeah.
can possibly imagine, and it is coming to the neural circuits. So that is what the ABCDSM is doing, is that we're embracing these new changes in neurology. We're implementing a lot with pediatric dental sleep medicine and our credentialing and our curriculum, and developing resources for the provider that are very passionate about pediatric airway. Because if we get it early, we don't have to fix it later.
I love this. And can you talk to us a little bit more before we leave about BabyLase? Uh, how did you even, start thinking about this? And what were the initial changes that you saw with these babies that just made you think, oh my goodness, we're onto something?
Well, first of all, I didn't want to do it because no one had done it that I was aware of. And one of the women who was at my the Make the Connection course, she was an infant feeding specialist, and she brought cousins into the office, one low tone, one high tone. And she's like, I need you to do to them what you did to me, because now I can swallow better and my range of motion is double what it was before. So if you can do that, I need you to help these babies. And I had to put on my chesticles that day, because it's not like that's evidence-based medicine, right?
Yeah.
But what was I going to do? This baby was on, a supplemental nursing system and was not thriving. And within 3 very conservative sessions, you could see this baby bloom and come back to life.
I have goosebumps.
And that's, once you see that, you can't unsee it. But what I also know is that information, because it had to do with the neurology and not just the tongue. You have to have people trained to understand the neurological issues, the feeding reflexes, and the things that go in with feeding, and not just looking at a patient as a tongue tie grading. It's much more than that.
100%. That's the beauty of treating these patients in this whole world of airway, how beautifully different specialties are coming together to treat these patients. A patient can come to me and I can do my myofunctional therapy exercises all I want, but if a patient is frozen, in those the neurological and there's so many other things. If their skeletal structure is not ideal, if they have enlarged tonsils and adenoids, whatever it is, we need the help of others. We need to treat the patient as a whole and not just do what we're really good at. We may get some benefits, but treating the whole body. This is incredible. You're doing some beautiful, beautiful work. And I would love for you to share again the courses in November. I would love to come. Is it somewhere or are they all online?
Most of the information of that last slide I can bring up again if you want me to.
Yes, I would love that. Are they in person?
We're trying to see if we're going to be able to do a virtual option
Okay.
for the Changing Minds meeting. Dr. Mate, we're so honored to have him, but he's like, yeah, you can't record me. So only the people there in person will be able to experience that. And we have probably, I don't know, 50, 60 members of the public that want to come, but I'm trying to save the seats for those in our professional communities to be there first before we allow the public into the private seats. So changingminds.health is the website for the conference in November. Okay. And the day before it is the hands-on portion where we teach everyone how to do the neurological assessments to determine if the patient's swallow has converted and is effective both neurologically and structurally, as well as their dental occlusion. And we go over other markers, the vitamin D, the ferritin, and Christy Gata, who is amazing, is going to be going over the control of the swallow. So it's just a super exciting event that I'm really looking forward to bringing to the medical community, getting them involved, as well as the mental health community into what we're doing in dentistry.
Perfect. I am definitely checking that out, and I will share the link with the Airway Circle Facebook group. If you guys are not a part of that yet, Airway Circle Professionals on Facebook, we have 3,400 professionals from all over the world and multidisciplinary, where we share research, we share cases, we ask questions, we try to find other professionals to work with. So if you're not a part of that, please join us. It is free and another resource we offer the community. I'm excited, very excited about this Changing Minds meeting. I'll be checking it out. And Dr. Tenholder, thank you so much for spending this time with us, for enlightening all of our minds over here. I really appreciate it. Any last words?
No, I just want to thank everyone for being dedicated to this cause. It's not easy to take the path less traveled and talk about airway and oral facial myofunctional therapy when there's people, basically pushing you in the water when you're trying to get out of the boat, right? But also to recognize that these patients need us to move forward with our thinking as well. We can't just always look at the things that we know. We have to be able to embrace the things that we want to know more about. And that's where the magic is. So thank you very much for changing your minds, allowing me to share my little corner of the world with you. I so appreciate it.
Thank you so much, everybody. Have a wonderful day. We'll see you next week. Bye.